program. Okay. So there's some meeting ground rules for hybrid meetings. By the way, thank you for joining us, and we've revised the rules a little bit for our hybrid format. Please share any, for the Zoom participants, please share any questions or tech issues in the chat. We will monitor the chat and do our best to be responsive. Please remain muted to minimize background noise for others. Auto captioning is provided. You may turn captioning on or off. Click on the caret symbol next to the CC Live transcript button if you want to hide the subtitles or to view the whole transcript. At the top of your video screen, you can choose between speaker view or gallery view, whichever you prefer. To all participants, we hope to have time after each speaker for a few questions. Virtual participants, use the chat feature to type your questions. In-person participants, raise your hand. We'll answer as many questions as we can, but we do have time limits for each speaker, so I'll be giving some warnings when we have to move to the next speaker. We will try to ask the questions from virtual participants. Sign language interpreters are provided at this meeting. If you need assistance accessing the interpreter, please put your request in the chat. And speakers, please say your name before you speak to help with accessibility. One more thing we would ask of everybody who's speaking up at the podium, if you can see before I started talking, I moved the microphone right next to my mouth so that we have full audio capabilities during this meeting. So just make sure that when you're speaking, you speak into the microphone, and you have to be next to this microphone as well, and try to avoid moving on to the side and speaking. If you do that, you will see something from the back of the room, like a raised hand, and that will be your cue to go back to the microphone. Okay. Thank you. Now, without further ado, all right. Meeting materials are posted on our website at the Milwaukee Mental Health Task Force. And on Zoom, virtually, Lisa Hassenstab well, it's sad because when we said someone's monitoring the chat, it's not someone, it's Barbara Becker is monitoring the chat. She's controlling things back there. This is her last meeting with us. And so that is sad. We hope to hire a new mental health task force coordinator this month, and stay tuned for details. Disability Rights Wisconsin will continue as the fiscal agent and the coordinator for the mental health task force. Lisa Hassenstab, who's on the screen, will supervise the new coordinator, and we'd like to introduce Lisa so that you can get to know her at this meeting. Lisa?
Hi, everybody. I'm Lisa Hassenstab. I am the Public Policy Manager for Disability Rights Wisconsin. I just started on July 31st, so I'm new to that role, but not new to DRW or the work of the organization. So really pleased to be with DRW and to be a part of supporting the Milwaukee Mental Health Task Force. I will be supervising the coordinator, who we are hopefully nearing the end of the process of hiring. So stay tuned for more information soon. But just, I don't need to say a lot, just want to reassure the task force that DRW is committed to continuing to support the work of the Milwaukee Mental Health Task Force. I have had the chance to meet Christine and Mary, and am already incredibly grateful for the leadership that they provide as co-chairs, and I'm looking forward to continuing to support the work. There's no one like Barbara, but we're going to do our best to continue supporting the coalition as best as we can. And if anybody has any questions as we kind of move through this transition, please don't hesitate to reach out.
Thank you so much, not only for speaking, but for making sure we have some security as we transition into the new era. So I'm going to introduce our first speakers. It's suicide prevention. What's happening in Wisconsin? So we have Erica Steve, Master of Public Health, Suicide Prevention Program Manager, the PRISM Program founder at Mental Health America, Wisconsin. September is National Suicide Prevention Month. Erica will share Wisconsin's strategies to prevent suicide and provide statewide data. Join us in this effort to raise awareness and increase prevention efforts.
Thank you. So yeah, my name is Erica Stein. I use she, her pronouns, and thank you, Christine, for introducing me. I will let my PowerPoint go. Yes. So this is a really quick presentation. I'm going to try to cover a lot of ground in 30 minutes, and hopefully we'll have some time for Q&A. So this presentation is going to go over what suicide prevention looks like on a statewide level here in Wisconsin, a little bit of data, and then strategies for prevention, and I'll also include some tips for talking about suicide. It's not letting me do the thing.
Is it turned on?
Is it?
On the side?
Oh, no, it's on.
It says it's on?
Yeah.
Oh, boy. Okay,
Oh,
well,
boy.
why don't you just let me go ahead and I'll, slides for you.
Okay, if that's okay, yeah, thank you. All right, cool. So yeah, before I get further, I just, whenever I'm doing a presentation, I like to give a little bit of context for what we call best practice language in suicide prevention. So obviously suicide is a topic that has, is still very stigmatized, but also has, a history of being seen as like a sin, a crime, etc. And so a way we can decrease the stigma around suicide and normalize it as a public health issue is to be intentional with how we describe it. And so I share this not to like police anyone's language or censor anyone, but just to kind of share like this is these are best practices for describing the issue. The field is trying to move away from saying committed suicide, as that implies like a crime. Instead, we say died by suicide. We don't talk about attempts in terms of successful or unsuccessful or complete or incomplete, but we talk about them as attempts or deaths. When talking about people who might be thinking of suicide or attempt survivors, we try to describe the behavior. So we might, rather than make judgments about behavior as manipulative or attention seeking, or like a cry for help, again, we just try to describe the behavior. And when it comes to mental health diagnoses as they relate, we talk about, we try to say like people who are diagnosed with so-and-so, and instead of, saying that we deal with suicidal people, we say we work with them. And there's a lot of other examples of this, and a lot of this is probably familiar to a lot of you. And again, this is just a cultural shift that's kind of happening in the field, and that's a little bit of why you see these shifts in language. We can go to the next slide. Real quick, I just want to give a little context for the organization I'm with, Mental Health America of Wisconsin. So we are an agency that does statewide work in a lot of realms. And then here in Milwaukee, we do have a physical presence with an outpatient clinic, and at different points in time been very involved in different mental health efforts, different suicide prevention efforts here in Milwaukee. But a lot of our work really spans the whole state. So I think like with these resources, you have all these links if you want to check out more about what MHA does. But the focus of today's presentation is on suicide prevention. So I'll talk a lot more about Prevent Suicide Wisconsin. But please note also that MHA has a lot of direct service and peer support resources that are available to people across the state. Around suicide, we have online support groups. One is for survivors of suicide loss, and the other is Alternatives to Suicide, which is for people who are have their own experiences with suicidal thoughts, feelings, attempts. So those are open to anyone. We also have peer support services. One is the PRISM program, which I founded, that provides free peer support to LGBTQ youth and adults. And the R&R House, which is a peer-run respite and peer-run warm line for veterans. We focus on those two populations because they are at disproportionate risk of suicide. But we also have Uplift Wisconsin, which is a brand new statewide warm line for the general public in Wisconsin to get that peer support. And it's currently operating 12 hours a day, 7 days a week. And you should have all these links to look more into it, but I just wanted to put that out there. MHA is involved in a lot of things and a lot of free resources that, we hope you'll share with the people you work with, and hopefully it can be helpful. So we can go to the next slide. So we really take a public health approach to suicide and suicide prevention. And I wanted to talk a little bit about what that means. A public health approach is really looking at all the levels that provide an opportunity for intervention on suicide and looking at the consequences of suicide on all of those levels too. So suicide is really not just an individual issue. It's something that affects the personal, it affects interpersonal levels, community levels, and the social level and policy as well. And so, yeah, it's really important to have this comprehensive approach to preventing suicide. There's not a one-size-fits-all approach. We need to work on multiple levels to really make the world more livable for people and to support people who are struggling. On a global level, the World Health Organization estimates that over 700,000 people die by suicide each year. So this is by no means unique to the United States. But here in the United States, a recent report came out with some early data on 2022, and it's estimated that 49,500 people died by suicide, which is higher, I think, than in years past. And data is still kind of being finalized on that. But I share that not to like sensationalize or strike fear, but I think it does show that this is this is a significant issue. And when we think about how all of those deaths affect so many other people, communities, and the ripple layer effects of that, it just goes to show that we this issue deserves attention and resources to solve it. So we can go to the next slide. I really love this graphic and I like to share it whenever I can. I think this is a really good visual digging deeper, breaking into the ground of like the underlying reasons behind this massive problem. So this graphic kind of shows like the earth and a shovel digging through, and like the top layers are like the medical model. Can't really read it. Pharmaceuticals, other things. So these kind of like surface level explanations for suicide, and kind of getting beyond that into, you know, more of the factors that really make people want to leave this world. And these are things like inequality, racism, homophobia, transphobia, injustice, mass incarceration, housing instability, discrimination. There's a lot of things here. And I think this is just a really eloquent and well illustrated example of how there's so many more factors than just mental illness. There's so much more that people need other than just that individual approach. And so when we're talking about suicide as a public health issue that really requires addressing all these issues, like this is kind of what we're getting at. And I always share this, and I always try to talk about this with people, because it's really important that we don't just think of this as a problem for psychiatrists to solve or the mental health field to solve. Well, obviously, like there's a lot of opportunity there, but there's so much more that needs to be addressed to really make this world livable. And the art is by Elise Ruriani, who I would recommend checking out. She was our keynote speaker at the Prevent Suicide Wisconsin conference this year. You can go to the next slide. This is another graphic. I won't read all the words. I know it's wordy. But this comes out of the Wildflower Alliance, which is an organization that I think does really great work in suicide prevention. So like, why do people think about suicide? Why do people want to die? And there's so many reasons. There's innumerable reasons. But you know, I think this graphic too does a really good job at illustrating just all the underlying feelings, right? Like we need to like stop thinking about suicide just as like one outcome that we're trying to prevent, because if we only focus on preventing death at all costs, then we miss a lot about what it is that really keeps people living and where the opportunities are, again, to make the world more livable. So like people might say they're suicidal because no one listens to them unless they say that. People might say they're suicidal because they're having big feelings and they don't know how to describe them. And maybe the system trained them that like they will only get the services they need when they say that. And you know, the offshoot there, like I'm thinking of killing myself because again, like these are innumerable reasons. It could be because like you know, I'm feeling unbearable shame, I'm feeling unbearable anger, I have suffered an unbearable loss, or I can't get my basic needs met, I want to be with someone who has died before me. There's so many reasons. And so when people are talking about suicide and talking about wanting to die, it's really important to not jump to conclusions about what it means for them and what they need. Yeah, there are as many reasons for thinking about suicide as there are stars in the sky. And we really need to keep that in mind, not just jump to conclusions about what it is that people are feeling and needing. Okay, we can go to the next slide. So I will start talking a little bit about our work here in Wisconsin. So Prevent Suicide Wisconsin is our statewide public-private partnership for suicide prevention. So it's administered by my organization, MHA, via a contract with the Department of Health Services. And the PSW coalition encompasses a lot of different partners working in research, working in education, in mental health, and primary health care, people working in peer support, people working with children, all kinds of representation in PSW. And it's really open to, again, anyone with an interest in suicide prevention, because we see that everyone has a role that they can play. So PSW, we do a number of things to advance the state suicide prevention plan, which I'm going to talk a little bit more about soon. Our task as a body is to update the state plan every 5 years, and then from there really oversee the implementation of those strategies, and working with again, more people across the state to implement them and make them work in their areas and fit to the work that they're doing. And so in addition to that kind of ongoing oversight, PSW is also just a source of information, a source of networking. We have a website, which I highly recommend checking out. We keep that very updated with trainings and different resources. We also have social media on Facebook and Instagram. We put out an e-newsletter. Again, highly recommend subscribing if you're not yet. We put out as many opportunities as we can find. And we have an annual conference. So that has been virtual these last few years. Usually happens in April. And I believe in 2024 it will be virtual again, but we are just starting to get into planning season for that. So we might have some kind of in-person component of it. So stay tuned. But yeah, that's a little bit about what we do and how you can get involved. We also have public meetings twice a year where anyone can just pop in and learn about what's happening. We can go to the next slide. So yeah, now I will talk a little bit about the Suicide in Wisconsin Impact and Response Report. So this is a document that includes data on suicide in Wisconsin and then strategies for prevention. So this most recent iteration came out in 2020, and it covers the data from 2013 to 2017. So it is a little bit outdated at this point, but we will be updating it. The goal is to have the next one published in 2025. And I'll talk a little bit more about like data in a sec. But yeah, we also, for anyone who's here today, if you're interested, I have physical copies of it outside the door. Highly recommend checking it out. It is a long document, but I think it's worth reading. It really, again, explores the issue. There's a lot of resources for action in that document. We collaborated with a lot of people to put it out. And yeah, there's just tons more resources and information. So if you're thinking about the work that you do and how you could apply that, definitely recommend picking up a copy. And it's also on our website too. So I'll go over a little bit of key findings from the report. So between 2000 and 2017, Wisconsin's suicide rate, so that's referring to deaths, it rose by 40%. And so that is a little bit higher than what we saw on the national level from that same time frame. In Wisconsin, just again, some quick facts from the report on a bird's eye view. Most people hospitalized or presenting in the emergency department with self-harm injuries were female between the years of 2016 and 2017, and that remains true now as well. Most suicide deaths were male in this time frame. The suicide rate was highest among the ages 45 to 54. And I think in more recent data, we're seeing that similarly, but the younger age range of kind of 25 and up is also seeing a rise. The Youth Risk Behavior Survey is a source of data that lets youth report on their own mental health and different behavioral health things. So that's where a lot of the youth data also comes in. So the Youth Risk Behavior Survey saw that suicidal ideation was reported by 1 in 6 Wisconsin high school students. And then LGBTQ youth report higher thoughts and attempts of suicide compared to cisgender and straight non-LGBTQ youth. We can go to the next slide. So some other key findings, in 2019, 850 Wisconsin residents died by suicide. The rates were highest among American Indian, Alaska Natives, and whites, again, in that 2013 to 2017 timeframe. Suicide rates were higher in rural counties than in urban and suburban counties. And veterans accounted for almost 1 in every 5 suicides. So for the data since then, we don't have it in the report, but we do have some data to share. Suicide data, the way it's collected, there's always a bit of a lag because of sometimes these deaths require more investigation to really determine if it was a suicide. And it takes some time for that then to be entered in the database. And so that's why there's always a bit of a lag. In 2021, 905 Wisconsin residents died by suicide. And in 2022, the data is not yet complete, but is projected to be similar or higher. We can go to the next slide. Okay, so there's, again, a lot more data in that state plan. And on the website, you can also like narrow in and look at counties as well. So if that interests you, you can certainly look into that. But yeah, all of our strategies for prevention kind of fall under these 4 categories. And yeah, we'll get more into them. So we can go to the next slide. So the first strategy for prevention is increasing and enhancing protective factors. And so by that, we mean the protective factors are things that really help people feel connected and yeah, getting the care that they need. And so this includes a lot of really specific items for action, again, that if you look at the report, you'll see, but they kind of, again, fall under even more narrow umbrellas. So implementing strategies that reduce the impact of adverse childhood experiences, so childhood trauma. Promoting healthy communities by increasing social connectedness. So yeah, probably one of the most important things is increasing that social cohesion, helping people feel connected to other people that really care. So that can look a lot of different ways. And then supporting efforts to increase safety with lethal means. So that's referring to things like firearms or medication, things that people might use to self-harm or to attempt. And so that could look like medication drop boxes, that could look like gun locks, things that just kind of build in some more time for people not to have access to those means that they could use to harm themselves. We can go to the next slide. Strategy 2 is increase access to care for at-risk populations. So that includes things like increasing the public's knowledge of risk factors and preparedness to respond. So that might include different trainings to help people feel more confident in talking about suicide and also helping people get the help they need. Expanding access to services and innovative ways to expand access to behavioral health services. So again, those are recommendations for like insurance to cover mental health and substance use treatment like they do physical health, as well as other innovative things like telehealth to increase access to care because there is a provider shortage in a lot of parts of the state, as well as things like apps and other peer support programming that, again, things that are beyond just like the clinical model, getting them access to care in other ways. So we could go to the next slide. Strategy 3 is implement best practices for prevention in healthcare systems, because many people who attempt suicide or later die by suicide, they do come into contact with healthcare somewhere along the way. So it is really important that we have better capacity to support suicidal people in those systems. So this can look like supporting implementation of evidence-based screenings, risk assessment and treatment, improving care transitions. So making sure people are supported as they're discharging from hospital and beyond, going back into the community. And then promoting a systematic zero suicide approach rooted in the understanding that suicide is preventable in people receiving treatment services. Zero suicide is also a training that MHA provides every year, and it also comes with a learning community after. But in a nutshell, it's a framework for increasing capacity for suicide prevention at every single level of a healthcare system. So it's a quality improvement framework rather than like a one-off training. We can go to the next slide. And then strategy 4 is improving surveillance of suicide and evaluation of prevention programs. So that includes improving and expanding evaluation of suicide prevention programs. So looking at them, looking at the outcomes, and really asking like if we're having the intended outcome, and if we are, how can we expand that thing? Using data to describe the impact and further the understanding of suicide, and standardizing and enhancing capacity for investigating and reporting suicide deaths. So yeah, again, how suicide is reported, how it's collected, makes a huge difference. There's a lot of opportunities for improvement in this area. Yeah, lots of opportunities to train medical examiners, coroners, police officers, and public health to be able to examine this problem in their community, look at the data, and apply it to their programming. And again, going back to LGBTQ youth, like I mentioned before, there's a huge opportunity there because, again, the way that gender and sexual orientation is collected on death certificates, we're missing a lot of that data. And again, that's because of this historic exclusion of this group. And so that makes it really difficult. It makes it really difficult to actually see the scale of the problem. So lots of opportunities to improve on how this is collected in data and reflected back. We can go to the next slide. I won't spend a ton of time on this, but I wanted to just plug some different trainings that we recommend for suicide prevention. These are some common ones. There's a ton out there. My personal favorite is from the Wildflower Alliance. When Conversation Turns to Suicide is a peer-based training, again, that really builds the skills to hold conversations with people about what they're going through and what they need. And it applies the Alternatives to Suicide framework, which, again, I mentioned earlier that we have these Alternatives to Suicide support groups for people to attend. And yeah, I personally, of all the trainings I've seen, I think that is the most useful in terms of actually building skills to talk to people about what it is they're going through and connecting them to help. And then there's others too. Assist, Talk Saves Lives, QPR, those are all really common ones. They can be, different trainings are good for different audiences, kind of depending on what kind of time you have. So those are some other ones that you've probably heard of. And I also wanted to let you know that the UW Green Bay Behavioral Health Training Partnership, in partnership with MHA, puts on a variety of clinical suicide care trainings each year. I think they might be done for this year actually, but we're going to be announcing the offerings for 2024 quite soon. So again, those are for more clinical providers, people who work in mental health, healthcare, crisis services, more geared towards a clinical approach. Some of them are like therapeutic models like CBT and other stuff like that. You can go to the next slide. Okay, and then to kind of wrap up this presentation, I wanted to share a little bit some tips for holding space for those thinking of suicide. Because again, I think a lot of people, because of all the stigma that's been around this topic for so long, people aren't always sure how to talk about this, and it can be really uncomfortable and scary, frankly, to talk to people about wanting to die. But I think it's really important that everyone feels confident with this, because really anyone has the capacity to support other people in their life, whether that's people in your community, in your circles, at work. And so I'm just going to share some tips from, again, the Wildflower Alliance training that I think is really, really valuable in their framework. So we can go to the next slide. So keep in mind, this is a framework taken from like a 16-hour training. So I'm going to go through it kind of fast, but I think it is really, really valuable. I think when we're approaching these conversations, we shouldn't think of them as like something that you're going to approach in a linear manner, that you say this thing and then you say this thing and then you say this thing. No, we really need to be able to change how we approach people so that we can actually hold a meaningful conversation with them. And so this VC framework is really a framework. It's not supposed to be step by step. But yeah, when someone is telling you that they want to die, that they're thinking of suicide, it if you can't do anything else, I think validation is one of the most important things. So showing someone that you hear them, that you see what they're going through, and that you know, it makes sense for them to feel that way. So validation might sound like, it makes so much sense that you're feeling this way. Thank you for trusting me enough to share this. I would be angry, sad, scared in those circumstances too. And it's so terrible that that happened to you. The next curiosity is the next one. And so by curiosity, we mean like giving people open-ended space to talk about what is really underlying that feeling. Again, not assuming that we know what they mean. So curiosity might sound like, what does that mean to you? How does that look in your life? And what has kept you alive so far? What happened around the time that you started feeling this way? And are there any things you want to do before you die? So again, curiosity can really open things up a little bit further and let people talk about, you know, that underlying reason. Vulnerability is the next column. So vulnerability as in sharing a little bit about yourself and your experience, which can, again, show people that you, that you can relate to what they're going through, and that, you know, when you share a little bit about yourself with someone, it can also make them feel safer to do so. So vulnerability might sound like, you know, when something like that happened to me, this is what I did. Or when I have felt really angry like that, this is what I did. This is a big one. When you're talking to someone and you're having these reactions to what they're saying, you could name that. You could say, I'm feeling afraid. You know, I'm afraid that like you're telling me you want to die. But I want to be here with you. And if you have limitations, like if you are you know, forced to report this to someone else, or if you have to go soon and you really only have a couple minutes, telling them, you know, I just want to be upfront that I have these limitations. And then finally, the last C is community. And so this is, again, more questions to kind of explore with them what community means to them and what other resources could help them. So community, this could look like, you know, do you know other people who have struggled with this? Have you asked anyone else about this? Who are the people in your life that have helped you in the past? And are there places or moments when you don't feel this way? So again, things that can kind of just open up the conversation a lot more than just, are you thinking of dying? Yes or no, and going from there. So next question, or next slide. And then, yeah, just like using that same model to kind of close out the conversation. When you're talking to someone, validation might look like, you know, thank you for sharing with me. It sounds like you're dealing with so much right now. Curiosity could look like, I'm wondering if you have thoughts on who or what might help you get through this to the next day. So kind of, again, looking forward and talking about that with them. Vulnerability might sound like, we only have a few minutes left together. I'm still feeling a little bit worried, but I feel good about this conversation. So again, sharing like how this affects you too. And then community could sound something like, I'm wondering if you'd be interested in checking out like a resource like Alternatives to Suicide Groups. Would you be interested in checking this out, where you can talk more in depth about this with other people who have been through similar experiences? So again, I share this, and I know this is super fast, but just to kind of show you a little bit about, about different ways we can approach this conversation, so that we can feel more equipped to talk about it with people and equipped to share those things. And of course, if you are really intrigued by this, I would definitely recommend going through the Wildflower Alliance training. And we can go to the next slide. So yeah, we're almost to the end, and then I'll take questions. So yeah, in summary, I know this is super quick, but main takeaways: suicide is a public health issue. It's not just tied to mental health. Wisconsin's strategies for prevention encompass a wide range of settings and sectors and populations, and there really is a role for absolutely anyone to do this work in prevention, and anyone can hold space for people who are thinking of suicide. So I think that's it, and then I can take questions. I don't know how much more time we have.
This may be
Microphone.
oh, I'm sorry.
There's a microphone. Where is it?
Microphone.
So you just make sure you turn it on the bottom.
I don't think it's that.
Bottom.
Yeah, I tried bottom.
Oh, wait, maybe.
How many advocates does it take? Let's see.
They actually don't want lawyers in the mix.
It's not lighting up like it.
The yelling doesn't work. And we have people.
I know, wait a minute. I just did a show. Yeah, yeah, thank you.
This, it's on, okay.
Okay, cool.
Okay, so this may be a longer topic, but just to kind of broach it a little bit is, I was at a rather disturbing county board committee hearing last night where they were discussing the Milwaukee County Jail and its budget and overcrowding, and particularly the 6 deaths in the last 14 months, including suicides that were probably most of them, or some of them at least, if not all of them, preventable. And so I was wondering, one, I guess if it might be possible for some people from the task force who are interested in having some influence on that issue to maybe brainstorm with you about some things that they might be offered as resources if they're willing to accept them. They're kind of caught up, was disturbing because it was all we're understaffed, which is true. We're under budget, which is true, but also overlooking the impact of locking people up for extended periods of time, just dismissing lots of signals so that qualitative, affective domain of just being aware of the people in their care seemed to be just totally off the radar in all the defensiveness over we're understaffed and we're overcrowded and all those things. So just wonder any thoughts about maybe obvious things to pass along to them about exacerbating risk by locking people up for extended periods of time, and also maybe just whether there's an opportunity to explore some resources or connections so they could have a little support for how to not have more deaths in the jail.
Yeah, and I appreciate you bringing that up. Yeah, I mean, I think like there's definitely a lot of opportunities there. And yeah, like we have to keep in mind too, like the jail is people have people haven't always even like been found guilty yet. There's a lot to be said for just like those inhumane conditions. So yeah, I think there's a lot of opportunities. I think that's something, if our ideas were welcome, I think that's something we would definitely talk about.
Barbara was, are you sure? Yeah, okay. We have put time for him, and Barbara's last.
Well, thank you.
Turn it on, Christine.
Yeah, it should be on, if you put it.
Hello?
Yeah.
There we go. I'm Kevin with Lutheran Social Services, and thank you for the presentation. I guess I was surprised by the number that in 2019 there were 850 residents who died by suicide, and then the number jumped to 905 in 2021, which would have been the first year of the pandemic. I don't want to sound negative, but I would have thought there would have been more because of the social isolation and everything that went in. So I guess that's got to be an encouraging sign, or are you still waiting for 2022 data to get 2 full years of the pandemic effect?
Yeah, thank you for bringing that up. I don't know why I forgot to put 2020 on there, but I don't know the exact number off the top of my head. But what is interesting in that in 2020, I think this was true in Wisconsin and nationwide, there actually was a slight dip in the suicide rate. And this has been seen, like a similar phenomenon has been seen in other like natural disasters and things that are really like collective traumas. Sometimes in that initial period, there's like this increased like resiliency because there is somewhat of a sense of like, we all need to struggle through this together. And that was very much the message in 2020. But then in 2021 and beyond is when we kind of saw more of those long-term effects of the pandemic, and also some of those social supports taken away. So some of those unemployment benefits and like child support benefits and other things like that. And then just like worker protection against the pandemic too. So yeah, it is really interesting, but that's kind of seen in other points in time too. So I think yeah, when I think about the pandemic and suicide, I want us to also think not just about like the social isolation that came from social distancing, but also like those like, yeah, economic factors that really change people's lives. Mhm.
Erica, this is Barbara Becker. I really wanted to thank you for the work you're doing and the resources that you shared. A lot of which were new to me. I'm really interested in what I wanted. So thank you for that.
Yeah.
One follow-up question, and I think so many people, remake and not very sensitive. And I just struggle, to know how best sources that you might be able to share with specifics.
Yeah,
Could be a follow-up for sure.
yeah.
Thank you.
Yeah, real quick, what I can say is we have online support groups for survivors of suicide loss. And we're gonna be working on getting an in-person group in Milwaukee starting again. But I think one of the best practices for loss survivors is to get them connected with other people who have been through that loss, because it really is such a unique type of grief that comes with a lot of its own stigma and difficulty and trauma. And so, yeah, getting people connected to support groups, clinicians who are trained in suicide loss, bereavement therapy. I'll also say the American Foundation for Suicide Prevention. They do a lot of really great work that focuses on loss survivors. So their awareness walks, like Out of the Darkness, can provide that community. Their Survivor Day events, things like that. But yeah, being connected to peers who get it, I think makes a big difference. Is that it?
Yeah, thank you very much.
Thank you.
Hi, good afternoon. My name is Christine Alstrup. And I'm a member of the Mental Health Task Force and also the Mental Health Steering Committee. One of the other things we're celebrating this month, besides suicide awareness, is National Recovery Month. I wear purple to celebrate National Recovery Month. And I think that it's important that we celebrate recovery because we need to take the stigma away. People don't seek treatment. People don't get what they need because there's a lot of stigma around substance use. And so National Recovery Month gives us an opportunity to put a face on recovery. I'm in long-term recovery. I share that with you so people can see hope. The best thing we can give to people struggling with addiction is some hope. In the presentation we just heard, we heard a lot about connection. People in addiction, when they're in the throes of their addiction, it's all about isolation. And recovery is all about connection. And so I'm really proud to have two people present to us on an organization in Milwaukee that's helping with connection. So people in recovery who are getting together, having some fun, hanging out, celebrating, putting a face on recovery. So to talk about the Phoenix, which is their organization, is Byron Thompson and Jason Seapluck. I think I said that right. Yes. Okay. So Jason and Byron are going to talk about the Phoenix.
Okay, you guys go ahead. Yeah. Hello. Thank you for having me, Christine and Barbara, and thank you for the wonderful presentation you just heard, which was super informative. My name is Byron Thompson. I'm also a person in long-term recovery. If I wake up tomorrow, I'll have 23 years of sobriety. Kind of odd, one of my best friends here, Jason, I'm just going to throw him out there and put him under the bus. He's also in long-term recovery, And the day after tomorrow, he will have 24 years of sobriety. He's one of the first people that I met when I came into sobriety. We've been friends ever since, and we got sober right here in Milwaukee. So Recovery Month means a lot to us, and we definitely want to be examples of people who can recovery is possible. And one of the ways that we that I got sober was to really make sobriety my whole part of my lifestyle. Definitely big advocate of the 12-step programs, many years, and 3 or 4 meetings a week, and outpatient treatment. And but here in Milwaukee, they have a great community as far as meetings after the meetings. So we'd go to a meeting, and somebody would say, hey, Milwaukee has a sober softball league, and or we'd go out for coffee, or we just more social. They would never let you just go to your car or go to the bus stop without, inviting you out. And I think that's one of the best things about recovery in Milwaukee. And so that kind of spurred me on to get involved in sober sports. I've been involved I was running my own program called Rebound from 2008 up until 2020 when I joined Phoenix. And Rebound was a Tuesday night basketball league for people in recovery, totally free, something I was doing as a volunteer. I was working my regular job and running Rebound on Tuesday night. But I would fool the people into thinking that they were just going to come and play some free basketball. But when they arrived at the gym, I'd have a circle of chairs in the middle of the gym, and we talk about, issues of recovery and how you're doing in recovery. Do you have a sponsor? Do you need a job? And so it was kind of almost like Phoenix-like program. And that particular program is what attracted the Phoenix to me. They heard about the Rebound program, and they invited me out in 2018 to Boston to witness a national program called the Phoenix that is very similar to what I was doing with Rebound basketball. But, they were doing just every other sport. They were, out in Colorado, they had mountains, and they were climbing mountains and running and doing CrossFit. And so I went out there for a seminar in 2018 and got to see, like, wow, the founder had the same thought that I had, and got the same energy from, not only just going to meetings and going to therapy, but working out together, sweating together, achieving goals on the basketball court together, and just building community outside of just the regular meetings. Sometimes we didn't even talk about, our recovery. Sometimes when we're playing basketball, we're just playing basketball, but we're all in recovery. We're in a safe place. Nobody's selling weed or, things that we used to do at sporting, when we used to play basketball. How I got in recovery in the first place, basically. So yeah, I just wanted to throw that out as kind of an overview. The Phoenix, like I said, is a national nonprofit. So, part of my job, I'm the regional partnerships manager with the Phoenix. I'm the programs manager with the Phoenix. And I'll say that because Jason and I are the only two people. We are the Phoenix, okay? There's no other people here in Wisconsin. So we pretty much we wear a lot of different hats. But we do have a volunteer program where the volunteers run our programs. And the Phoenix is a free workout or a free social activity for anybody that has 48 hours of sobriety. We try to have a program going every day of the week that after you do your meeting, after you go to your therapy, you can come out. Tonight's volleyball, 7 o'clock. Sorry about that, the phone. And so we have an app. You can go on our app or go on our website and find a free program every single night. And everybody that's there is going to be either in recovery or an ally of people in recovery. So, yeah, I don't know if we she went to the next slide, so I was gonna bring,
I'll go
oh,
back. Do you want me to go?
no, stay right there. No, that's fine. I was gonna bring Jason up to talk about a little bit about the history, but a lot of people, sometimes I go to these, do a presentation and people, they end up, what is the Phoenix? Okay, what exactly do we do? And that is provide, yeah. Oh yeah, sorry, we did skip this one. Our mission statement here is, the Phoenix mission is to build a sober, active community that fuels resilience and harnesses the transformational power of connection so that together we rise, recover, and live. And really the key word there is, as was said in the last presentation, is connection. The fact that we're all like-minded, we're all in various stages of recovery. Some people have, when we're rock climbing at Adventure Rock, which is one of our partners, the person with 30 days is climbing right next to the person with 5 years. They strike up a conversation, they build connection, they have coffee after. That's the, kind of the way the Phoenix works. We really believe in the power of like-minded individuals sweating together, working out together, but also doing social activities like art and karaoke and stuff like that. That's our mission. We really believe strongly in bringing people together. And part of my jobs in partnerships is to go around the city and make this pitch that you could donate 2 hours of your gym time to letting the Phoenix people come in, because it's a free program, and give us 2 hours in your gym when you're not busy. So Adventure Rock, which is one of our partners on the east side, they give us Saturday night. Nobody's really they're not that busy on Saturday night. People are out in the streets. So from 6 to 8, you can come and rock climb with the Phoenix. We partner with all the sober houses, all of the treatment centers. Sometimes there's a van dropping off 20 people at rock climbing, and we didn't know they were coming. And that's really one of our biggest events. But so we got basketball, volleyball, climbing, yoga, just anything that you can imagine. Anything can be in a Phoenix event. Somebody might come up to me and say, Byron, we got all these events, but we're not doing any snowshoeing, or which I didn't even know what that was. So I'll say, well, you know what? We're going to have snowshoeing, but you're going to be a volunteer and you're going to lead snowshoeing. So don't never say that we don't have something, because then you'll be leading it. I'm going to bring up Jason and talk about a little bit of our history here in Milwaukee.
Hi, everybody. Jason Seapluck, and I'm the volunteer coordinator with the Phoenix since January of 2021. And I guess first I'd like to just say that when I hear the words mental health, I think my mind like a lot of people probably goes automatically to doctors and physicians and psychotherapy and medications and antidepressants and stuff like that. And so there's a lot of ways to combat mental health issues, and in our space, with addiction, what we do is the power of connection, which a lot of people have talked about today already, and physical fitness. Those two things can really make a difference. And personally, it's something that works for me on a daily basis. Staying connected to people who are in recovery, like-minded people, and really staying active, whether that's going for walks or doing yoga or playing basketball or whatever that is. There's so many benefits to being active and to staying connected. So just the slide here is a little bit of a history of the Phoenix. So started in 2006 in Boston, quickly made it to Denver. And like Byron had mentioned, they're doing some kind of extreme stuff, so they're like ice climbing, and they're climbing mountains, and they're trail hiking and stuff like that. And so that model has kind of changed to where like almost anything can be a Phoenix event. And so meditation, painting, going for walks, the sky's kind of the limit as far as Phoenix events goes. So that's kind of changed for us and for the better. We are in 46 US states and 2 countries. So we're in Canada and in the UK now. So we're excited. That was just recently, not long ago that we made it international. So we're excited about really spreading this community everywhere. The Milwaukee chapter started, Byron talked about a little bit. In March of 2020, they decided to come start a chapter here in Milwaukee. And all of our events are led by volunteers, which is kind of unique, and so anybody can raise their hand. They can share their time, their talent, their interests, whatever that may be, bicycling, maybe it's poetry, maybe it's writing workshops. Anybody can share their time and talent. They can raise their hand. All of our training is done through our phone app, which makes it kind of easy. They then would have the ability to start their own Phoenix event. And something unique that we started probably a year and a half or so ago is that you can become a remote volunteer. So if you live in Wausau, Wisconsin, and you heard about the Phoenix, you can go through this training and you can start a local event there without, someone like Byron or myself there. So we'll train you to start events and start growing a Phoenix community wherever you are. And events can mean a lot of different things. So there are in person a lot, and we pride ourselves, Byron and myself, on the weekly events that go on here in Milwaukee and getting people together. But virtually we have an extensive list of events that are also volunteer led. So on our website or on our app, there's 8 or 9 events per day that people can sign up for and join for free. Camera on, camera off. You can be as incognito as you want, or you can join in the workout, or you can join in the yoga, or join in the conversation, or you can just listen or watch, or it's really kind of open to what you want it to be. And special events are something we really like to do as well. So throw a big party. We had a sober tent at New Orleans Jazz Fest this year, and just locally here we had our own sober festival, our 3rd sober festival, with over 350 attendees. And something that really hasn't been we haven't talked about yet so far is that our community is open to allies as well. So it's really anybody who's been sober for 48 hours can attend. So mom, dad, brother, sister, husband, wife, all welcome to attend our events too. So I think I'll turn it back over to Byron now to talk about a little bit about the Milwaukee area stuff.
Okay. Yeah, our virtual program is a great way. Sometimes people have, they're a little afraid at first to walk into our doors, but all you have to do is go to our app. Our app is the Phoenix. Just go to the Phoenix at any store. It's a free app, and you will be able to join a virtual class where you can do that right from your home. Camera on, camera off, like Jason said. And I'm telling you, we've got virtual pro like 8 a day going on. 7 days a week, you can get into a yoga class. You can be up. During the pandemic, I was in my attic doing like workouts and stuff. And sometimes I get tired. I just cut my camera off and then I get back in. Slow down. I had to get some water, but yeah. So it's very they cater it to different levels. Everybody is not super worked out. They make sure that it's comfortable for everybody. You can stop at any time. If because we got people who have 5 years of sobriety, they may have been working out. We have people that are coming, maybe they may have just left detox. So that you can go at your own pace. That's definitely something one of the differences, another thing I want to mention is, people say, what's the difference? I can just join a gym. The difference with the Phoenix is every group, we're gonna circle up. Before we start playing basketball, before we start doing yoga, we're gonna circle up and go over our community standards and have an icebreaker and just kind of build community that way. So that's one of the differences than you're not gonna get at the gym. And like I said, we're also yeah, so we've been doing great since 2020. But these are kind of this year's numbers, which we've got over 5,200 people that have attended our events up until August, and 54 volunteers, which is awesome. We have an army of volunteers. Like I said, like Jason said, we had the Sober Festival at the Pier Marquette Park, right downtown, and we just had an army of volunteers that were, helping us, put the stage together and passing out swag and merchandise and stuff like that. And of course, we, as a nonprofit, we partner with other nonprofits. So, if you've heard of any of the sober houses, Made a House, of course, Fourth Dimension, we built a community of partners, and a lot of us, of course, seeking the same funding, or maybe funded by the same foundations and stuff. We like to work together. And Milwaukee in the Phoenix realm is unique for our team sports. When like Colorado is unique for ice climbing and stuff like that. Nobody does team sports like us. You know what I mean? So we get calls from all over the country from other Phoenix people. How did y'all start the softball league? How did you, because we got 4 teams at Bradford Beach. When you see all those people out there playing volleyball, so we got 4 sober teams out there in that group. And we started off in 2020. We had 1 team, and now we have 4 sober teams, and we got big sober shirts on. Everybody's like, "Oh, those guys are weird," and we're having the most fun out there, So yeah, we're very proud of that. And again, Sober Fest is our music festival where we pride ourselves on being, hey, so Summer Fest. Every festival you're gonna go to, you're gonna that cloud of weed is gonna be in the air, and people are gonna be drinking, but not our festival at Pier Marquette for one day every August. There's mocktails and wonderful mocktails that we partner with the local mocktail bar that serves non-alcoholic drinks and free food, and you don't smell no weed, and everybody. I mean, there's always like people, we don't run the park, so there's always like a couple of people in the park, but I mean, like, they are totally the minority. You'll see, like, they're like way over in the corner and they're drinking the beer. We're over there, like, what I mean? So, I mean, we're the only sober concert in Milwaukee, and we know that, and we're proud of that. So, yeah, that's the Phoenix. We're, before we got into, working in this industry, I had a job. I was working in housing when I was doing my rebound thing. And so when you work in housing, you got to collect the money and stuff. So you're always the bad guy. So, but with the Phoenix, all our programs are free. So we're the good guys. So everybody's always glad to see us. So that's a change in career. So yeah, do we have anything else? We got another slide?
Yeah, we do.
Oh, okay. Well, I'll go sit down.
I'm just gonna go through this one quick. I think we covered a lot of it already because we jumped all over the place. So how to join the Phoenix. So be a person in recovery or an ally or sober curious. If you just have that idea that maybe it's a good idea to lead a sober lifestyle, you're obviously welcome. We are right now only 18 years and older events. So I just want to put that out there. It's easy. Download the app, sign up for a class, show up. We make it real simple that way. You can become a volunteer by raising your hand, by talking to me, by downloading the app. After you go to your first event, you are then eligible to become a volunteer. You can become a partner. So Byron talked a little bit about Adventure Rock. You can become a partner of ours. we'd love to work with different organizations. You know, a lot of people attended, a lot of organizations attended our sober festival this year. So I just want to throw a few things that we're not, you know, we are not treatment. You know, we don't have transportation to events right now. We're not sober living. We really are just like, let's connect, let's have fun together, let's have fun in sobriety. So that's all we have, I think.
Any questions?
Some of it.
We have time. Time for a couple.
I'm gonna take the ones in the chat first.
I missed them, sorry.
Start with.
I just wanted to say that you guys are on the right track. In 1998, I started recovery this here in Milwaukee. It's just something that I did. I found the need for it. And actually, a couple people in this room participated. One week we'd have an event. And one week we'd have a meeting. And it was just something that was spearheaded. I did that until I went into graduate school. It was on a calendar for about 5 years while I was in graduate school, and I continued to get phone calls. So I'm glad that somebody took something over in 2020 that is needed in the community. And my question is, do you have anybody doing any activities for people that have limited physical abilities? You know, like anybody doing bonfires or anything like that? We're all out of bonfires.
So great question. Thank you for that. A number of social activities. So things like karaoke, painting, walks. I know that's still limiting for some people, but we do walks. And I think, you know, personally, I think yoga is for everyone, you know, and that's always something where yoga teachers are very cognizant of people's abilities and can really teach a class based on, you know, what people are capable of. So I think those are some that are on our schedule right now that people can attend. But we're always looking for people to start more.
Definitely, you know, it's done in the Phoenix. We just haven't done one yet. I mean, but I've seen them in other states where, like, you know, that's an event. And I guess, you know, I don't really know how to make the fire, but I'm from Chicago. I gotta tell you, I was born in Chicago, so I don't know where to handle the woods or anything.
This is Barbara. I just wanted to thank you. I mean, your enthusiasm for this work is amazing. You really have a passion. So thank you for what you do, and you know, I hope that we can help be a good partner in terms of getting the word out to the community. And are your brochures available electronically as well? Yeah, everyone be sure to take all the materials that are out there and get them out to the community.
Yes. Also go to the website, thephoenix.org, and I can always send a trifold, you know, to anybody who wants it, anybody who emails or anything like that. And I will say, I mean, I'll be honest with you, I'm so appreciative of, you know, I mean, think about it, I'm a person in recovery, and now I'm getting to speak, about something that I'm really passionate about that I never knew that I would be doing, and something that I was, be honest with you guys, I mean, I was doing this stuff for free, and now it's my job, you know what I mean? So it's really like a labor of love. We loved doing this. We go all over the state trying to, you know, pump it up, and honestly, you know, part of our job is playing volleyball tonight. So. We got a good job. I got you on fire. Get his name. Quick question. So, I'm going to I would say, yeah, I think that's like definitely like our, we're in recovery, man. You know what I mean? And the people, a lot of the people that we partner with, that's where those conversations are gonna come up, because somebody, they're gonna need housing, they may be, in between housing and stuff like that. And we've been through all of that. And those people are our partners. Those are the people that are at those tables at our Sober Fest, all of the resources. Those are the people who we partner with at our events, so every table, we pass out Narcan at Soberfest. And I know for sure, not this past Soberfest, but last year's Soberfest, one of those Narcans was used like a few days later to save a life in the neighborhood. So definitely, that's where the conversation, that's where the circle up and the after, people always, if I tell you, one thing about this job, I mean, people in recovery will contact you at any time of night. You know what I mean? They will send me a instant message, or you know what I mean? Like, hey, hey man, it's 11 o'clock, but I always, answer, and that's just part of what we do. So absolutely, yeah, we got the resources, and we don't have that resource, but we can point you to it. So we pride ourselves on that.
Gentlemen, I have one question. This is Nicole. I'm from Independence First, and so I'd just like to go back to Barry's comment on accessible activities. But I'm also wondering if Phoenix has funding to pay for interpreters at their events, ASL interpreters, other language interpreters. How are you opposed to making something to participate?
Yeah, I can take that question. That's kind of a difficult thing to plan for. Sign up is basically open to the public, and someone would definitely need to contact us first to say that they have signed up for this event and that they would need that type of thing. I think it's definitely within our budget to do something like that, but with all the attendees that we've had so far, we've never had that actually come up virtual. I would need to get back to you regarding virtual. Yeah.
And I'm sorry, I'm not using a microphone, so I'm gonna yell across the room. But I'm wondering if folks are asking for accommodations because they don't know, or that you're not getting participants because they don't know that accommodations could be made for the event. So Independence First, I'm sure we'd love to partner with you all and go over those considerations.
That's great. I mean, that would be a great, I think it would be definitely a great way for us to partner. I mean, it was something like, I remember during the pandemic, that's really when we switched to virtual, and that was on the table. That, there was a couple of people, that was coming up, and there was a couple of volunteers that were doing it on some of the virtual programming, but definitely have not heard much, it's not something that's totally in our program. And we could be, one of the things about, the Phoenix, they definitely give us the, like the freedoms and the power. Like, I mean, if we wanted to partner up with you all and do that, they would be all for that. So definitely, let's connect on that.
Thank you very much.
Thank you very much.
I am Sue Goddard. I'm a member of the steering committee. I'm also an individual that's in long-term recovery. I established my recovery in 1995 without bicycling and sober softball. I probably would not be standing up here today. I know that to be true. I want to draw your attention to the information that is in your packet, but then there's also on the website for the Mental Health Task Force. There are a listing of resources. It's 2 pages long, broken out really into general information and then 4 specific pillars: prevention, harm reduction, treatment, and recovery. You will need to go to the website to hit these links because they are live links. So all you have to do is click it. So we try to provide to you the current information that we had. Most of the information is from 2023. I'll just draw your attention to a couple things. Obviously, there are resources under the general information category for your ability to celebrate the Recovery Month events from both Faces and Voices of Recovery and SAMHSA's website as well. Please think about planning for National Prescription Drug Take Back Day, which is October 28th. I know we've talked a little bit about drug disposal. They have links on there for Dispose RX and the Deterra bags. Obviously, there's information for prevention, for harm reduction. One thing I just want to draw your attention to is that there was an approval by the Food and Drug Administration of a second nasal naloxone called Revive. So you will now have the ability to have two. Narcan is out and is available now. As of last Friday, it was available at Walgreens and at CVS. Come January, there is another medication that will be available over the counter called Revive. It is at a much reduced cost from what Narcan is available. And then since I've worked in the field of women's treatment for quite some time, please take a look at Tough as a Mother, Stronger Than Addiction. It is an anti-stigma campaign for pregnant people who are, trying to address their substance use disorders and bring a beautiful child into this world. So thank you all very much. I will now turn it over to our dear friend, Mike Lappin. Right? We good? Oh, it's just resources. Hit the links. You got to go to the website, go to the Mental Health Task Force so you can get the live links. Thank you very much.
Hi, everybody. It's been a while. I was here for the county executive's budget briefing, but didn't get the pleasure to address the group. So it's been a few years since I've been able to talk to you guys in person. Certainly something was lost online. So for all you folks out there joining on the web, maybe next time we'll all see each other in person. Barbara provided me with some questions that I believe were generated by the group. So I'm Mike Lappin, I'm the administrator for the Behavioral Health Services Division in Milwaukee County. We've operated a series of programs and institutions up until a year and 2 days ago on the county grounds for 142 years. We opened our first facility on the grounds. The first hospital, March 26th, 1880, we closed our last facility on September 9th, 2022. So that's the number that I have to get in my head because I know the old history, but the last year has been pretty complex. So the first question is about the Mental Health Emergency Center. Just asked about some stats, so I will share those statistics with you. I guess in a nutshell, I would say that the Mental Health Emergency Center has really surpassed all of our expectations in how it's operated. Starting something like that from scratch with pretty much an entirely new staff and just with the loss of some of the institutional knowledge that was part of the Behavioral Health Division was a big risk. Our partners from Aurora have been amazing. The team, particularly Dr. Julie Owens, the Chief Medical Officer, has made some really serious improvements on what was the original plan. It was very thoughtful, but over the course of the year, they've become a much better program. I have July data. I would have provided this ahead of time, but I only yesterday presented it to the Mental Health Board, and we have a policy of not releasing data until it goes to the board first. So July, we had 731 encounters at the Mental Health Emergency Center, 609 adults, 122 youth. The mode of arrival, 12 people came by ambulance, 577 came with police, and 142 came either by family or self. Legal status at admission, 349 voluntaries, 382 involuntaries. Legal status at discharge, 588 voluntary, 143 involuntary. So these numbers, and I have the whole year, very similar to the voluntary and involuntary numbers at PCS. Very similar adults and youth. So I spent about 80-20. The legal status at admission has typically been about 50-50, sometimes 60-40. But if you really draw out the numbers over the years, so some of the positives of the Mental Health Emergency Center, we're supposed to be vacation and more people will be accepting that service. I think that has panned out. We're on pace for right around 8,000 visits. The last year at PCS, I think we were down to about 6,200 visits. So we always believed that we would see between 8,000 and 10,000 people at the new location because it was so much closer to the people that we serve. You guys have heard the talking point. You know, we did a heat map of the Milwaukee community, the individuals utilizing the psychiatric crisis service. 93% were the city of Milwaukee residents, 70% lived in 10 zip codes, 8 on the north side, 2 on the south side. So there was a heat map created. Right in the center of that heat map was the 53205 zip code. Right in the center of that zip code was the county-owned parcel that became the site for the mental health emergency center. So this is a thoughtful thing. We built it because we knew that's where people were living, and we wanted to make it so it didn't take you like 3 buses to get out to get the mental health care that you needed. Barbara asked me about some of the discharge stuff. So I have some year-to-date data here. So July, these are people being discharged to inpatient. 47 in July went to Granite Hills, 35 went to Aurora, 18 Rogers Memorial, 8 were admitted directly to the mental health emergency center. We do have a small number of beds there. 2 individuals went to Winnebago, and 2 individuals were accepted by Ascension, that'd be St. Francis. Year to date, so this is just 2023. So through July of 23, Granite Hills has admitted 248 individuals, Aurora 246, Rogers 81, 65 have admitted to the mental health emergency center. 27 have been admitted by Ascension, and 15 cases have gone to Winnebago. So these are the sort of high level numbers. Again, if I look at it for children, Granite Hills took 12, Aurora took 12, Rogers took 1 youth was sent to Winnebago. Yield to date, it's year to date, it's Granite Hills 74, Aurora 65, Rogers 34, and Winnebago 5. So just gives you some basic information about the people served, their discharged dispositions, but really that stat about legal status of discharge is, I think, the most important thing here. Many people come to the mental health emergency center in police custody. They've been detained by police. They come to the mental health emergency center. They are assessed physically. There's a standard EMTALA screen. So EMTALA is the Emergency Medical Labor and Active Treatment Act. Requires us to have an assessment with a medical provider to make sure that you're not having an emergency medical condition. Once that EMC is ruled out, an individual is assessed by a physician. We maintain, Milwaukee County has a credentialing system. They must, at the mental health emergency center, have a physician who is credentialed by the county department to act as a treatment director designee. What that means in Wisconsin is Milwaukee is unique in the fact that the statute says it's counties over 750,000, but obviously that's only us. Milwaukee County must provide a physician to assess an individual who is held under emergency detention within 24 hours of their civil liberties being suspended. So that means is a physician designee physician by us must see you face to face and complete an assessment in order to demonstrate that you actually meet criteria for inpatient admission against your will. So everybody who comes through gets an assessment. The reason it goes from, about 50-50 to a great majority of folks who are voluntary, it's because so often people are brought there who do not meet criteria for involuntary care. Many times people are seeking help. That's the irony. And in Wisconsin, if you are willing to accept help as a voluntary person, you can't be held against your will under Chapter 51. It's a common sense fact that really people struggle with. That if you will say, well, I'm happy to go follow up with this provider. Many times people have a treatment provider, maybe they've had some challenge, they maybe lost track with their caseworker, they couldn't get in to see their physician. There's any number of things that we can, dispositions that do not require an inpatient hospitalization. And in fact, for many people, an inpatient hospitalization is a problem because it causes them to miss work. Depending on your insurance, you might have a serious copay. There's all kinds of life disrupting factors that could happen in inpatient hospitalization. And there are very effective programs available in the community-based programs that we've expanded in Milwaukee. And there's a lot of opportunity for people to be served in another setting. Looking at some national data here, the state that involuntarily holds the most people is Florida, 986 per 100,000. The lowest is Connecticut at 29 per 100,000. So think about that. We're right in the middle. So you could argue that Wisconsin Milwaukee probably has the most progressive involuntary mental health system in the country. It's not a shocker. Some of the laws that define that rule nationally happened here. So there is a little extra attention paid here, but Lissard v. Schmitz, a couple other decisions. So, but we do our best to make sure that people are served as voluntary customers as often as possible. And we also want to make sure that people are in the least restrictive setting. Least restrictive setting has been a real challenge, as often the customers we serve have a different idea of what they want and what they need than maybe a person in their life or a family member or a neighbor or whatever. And so we kind of get into these arguments over what is appropriate. Whenever possible, we want people to be served in a setting they choose and live and make those decisions about their life that they certainly have the right to make. We recognize that people with a mental illness aren't defined by that illness. They're people with very complex lives, and we want to make sure that all those aspects are addressed. It's hard to address someone's life in a hospital. It becomes a very narrow focus. Hospitals are very formulaic. Everybody gets the same treatment plan. Everyone has the same discharge thing. It's get out of the hospital as quickly as possible. You have to see a psychiatrist. You typically get prescribed medications. There's so much more to life than those things, as our friends from Phoenix have demonstrated, that really the idea here is to connect people back to their community so they can thrive and do so in a least restrictive setting. So I'll certainly take any questions later. Those are the basic stats for the Mental Health Emergency Center. We expect a full year report to the Mental Health Board Quality Committee at the next meeting, which is on Sunday.
That's a public comment.
No, there's 3 months from now, so we just had it this week.
We just had our meeting Monday.
Yeah, so
it's the second Monday of December.
Yeah, the second Monday in December, we'll have the full year report. We've had a little trouble getting the bugs out of the data. They use the Epic system. It's been a trick to pull reports out, deduplicated reports out of Epic. The other question that I was asked is update on inpatient services. So I know Dr. Sanders is coming from Granite Hills next time, so I'm not going to steal her thunder, but we've had some challenges. Our original arrangement with Granite Hills, so Granite Hills, I believe you're all aware, is a hospital in West Dallas that is operated by UHS. After about a 5-year due diligence process, the county entered into a contract with UHS to open that facility. It's hard to believe that it's true, but I believe it was February of 2018 that we actually approved that contract. Took a little while to get things executed. Some of it was on their end, some of it was on zoning. The West Dallas Zoning Board had some things to say about what we could do there or what we couldn't do there. But eventually the hospital opened in January of 2022. The anticipated census was to be 120, so 5 24-bed units, 4 adult units and a child unit. To date, they've only been able to open 36 beds for adults and 12 beds for kids. Just on last Monday, they expanded by 12 beds. The real challenge for them has been recruiting and retaining nursing staff. Pretty much our industry right now is the rate limiting factor is really nursing and physicians. So they entered the market, and people who've been critical of us. We closed the VHD hospital last year, as I mentioned. How could you do that without this plan in place? So the truth is, we would have been in the same boat. When we closed in September, we were at about 85% temporary staff for nursing. So we were paying travelers. It's really hard to staff a facility that's closing, for one. And the other piece is just in this space, it's very difficult to find staff who are enthusiastic about providing the kind of care that we demand. So we want very high quality care delivered by very experienced people. Those folks are in short supply right now. Nobody saw the pandemic coming. The pandemic really decimated the healthcare workforce, which you've heard from everyone. I'm quoted in a neighborhood news service article, I believe, that came out last week, but I thought it was fair. Many have been critical that Granite Hills has struggled to staff their hospital. And I'm frustrated that they weren't able to staff their hospital to the planned number. But in the last calendar year, we've had 3 local health systems close a psychiatric unit, and site staffing is the issue. So you had, Freighter Menominee Falls, you had the St. Mary's North facility, the old St. Mary's Hill Hospital. And then they transferred all the staff, to another facility that went from, I want to say 20 beds to 2. And now St. Luke's South Shore has consolidated their staff to the Aurora Psychiatric Hospital facility in Tosa. I'm told, and I believe their team, that they were able to actually increase their census at Aurora at APH because that's a very small unit at St. Luke's South Shore. So they had a fully functioning psychiatric facility inside the hospital. They had, I believe, 10 beds. The same staff could probably serve 16 or more clients at their APH facility, which has been very much remodeled and also has all kinds of ancillary services that don't exist in that hospital setting. But the point is, that is a loss. So any given day, there's about 10% capacity in our system that is available. I heard some feedback from the community that people are often not able to get admitted as voluntary patients. Really, that comes down to the physician who's assessing that person and writing an admission order. And most days there's capacity, it's just very limited. I think that's the challenge. And you know, the hardest part about that is we really can't predict what the census is going to be tomorrow. Yeah, Barbara.
Mike, could you just clarify how many psych beds are left?
However many are operating at St. Francis today, so less than 10.
Oh, man. And is Freighter, I thought they were opening a unit?
They do. They have what they've been referring to as a med psych unit, but it doesn't operate like a psychiatric. So it's a med surg unit that has some capabilities for people with mental health issues, but it can't function as a psychiatric unit. They don't have locked doors. They don't have restrictive measures. They don't have those sorts of interventions that a psych hospital would have to have. So that's the inpatient story. You know, we continue to make progress. Dr. Sanders, she's been a guest here before. I mean, she's a local person who understands our service. She understands the community. So we were really struggling with some of the staff that were temporary staff at UHS coming from other jurisdictions and not really understanding the Milwaukee community. So it's a plus to have someone there who really gets what we do. And you know, she's been part of an agency that delivers community support program services and targeted case management. Okay, all these services that are part of our community, and that, you know, Granite Hills just has to be another piece to a very complex puzzle of community care. So community crisis services, update on community crisis services, expanding a mobile crisis capacity and progress filling open positions. I wish I had better news. We've been advertising in all kinds of formats for about a year. We've had a few positions filled. Unfortunately and tragically, we lost 2 of our long-term crisis mobile staff in the last few months. Unexpectedly, we had 2 staff pass away unexpectedly. One of them was like an anchor on our second shift, was just a rock star. So that really set us back. It really is hard on the team, just emotionally, and losing someone like that. And then to try to replace 30 plus years of experience on that shift has really been challenging. So staffing is our greatest rate limiting factor today. We are still doing crisis mobiles. We are still running CART. We are still out there. But it really it's a lot of extra shifts picked up by folks. I mean, we're doing our best. We recently moved forward with a campaign really pivoting to focus on interns and really generating more internship opportunities. Today we have 7, I believe, paid interns. Those are all internships. Those are all full. We have 11 unpaid interns, or up to 18. And we put 4 more paid interns in the budget for 2024 because it's obvious that if you have a paid internship, you're going to attract more candidates. The higher rates on our interns, either internally or through one of a partner agencies, has been very high. So we believe that's probably the best way for us to grow our own workforce, is literally start folks out, be their first job within their master's program, or even as bachelor's folks, educated folks, and create a path for them to be part of this career. So it's one of the great things about Crisis is it's 24/7, 365. So we can put together a pretty compelling job offer for someone who can also go to school and continue. We can pay them with a bachelor's degree, and they can earn their master's and get some really great experience along the way. A big part of what we're going to be doing going forward is really selling this career in mental health, a career, you know, as a mental health provider, practitioner, as a mission sort of aligned thing, really targeting our Milwaukee community. I know there are people out there that would be passionate and all about this. Most of them never heard of it. You know, I know my first experience really was just sort of happenstance, and I literally got sent to an internship at a psych hospital, having no knowledge whatsoever of it. And here I am, like, I can't imagine doing anything else. So we want to expose as many people to this. We also want to make sure that we're thought leaders and really spreading the word about what good treatment looks like and recovery focused interventions, really celebrate our community and what we've been able to achieve here. Barbara asked for an update about our youth crisis facility for boys. The YCSF was a project that we have elected to end. In fact, admissions have already ceased. The story there is we worked really hard with WCS, who did a great job. We tried to market this service. We went through every channel we possibly could to generate referrals, but we could not achieve a census that averaged more than 2. And for the project to work, we needed between like 4 and 5. And at 2, it just did not work within the way the state reimburses us for crisis service. There was some grant funds supporting at the beginning. Again, it wasn't anybody did anything wrong. People worked really hard. We just did not generate those referrals. I'm still at a loss to understand why we didn't get more referrals for that facility. A big challenge, though, that I'm observing is that some of these youth were involved in the courts. They had some sort of entanglement with either youth justice or child welfare. And what we found is the judges were not comfortable referring someone to a non-locked facility. So anytime you have a facility that people just walk out of, there was less faith that that facility could keep people safe, even though they had a really good program and had great outcome data and everything. There was a reluctance to send people there who were higher risk, and so it further shows us that there is a missing level of care in our system. I saw just today, and I don't know if Mary saw this, but just today, a new bill is being released for review at the legislature that would create essentially a new level of care in Wisconsin, a crisis stabilization facility. They did so with input from DHS, from the Department of Permanency, Safety and Permanency, Department of Child and Families, and a couple of law enforcement was involved. Of course, they have their own sort of interest in this matter. But the truth is, a lot of them are trying to be like us and have alternative facilities like the Mental Health Emergency Center, like the Crisis Resource Centers. I think every community would benefit from Parachute House, these sorts of things. But there is a missing piece to our system that if law enforcement could bring somebody to a facility and leave, and we had a day or two to help sort out what that person needed, it would lead to many better outcomes. Unfortunately, most counties literally take every single person that they detain to Winnebago. And that's why the state hospital is so overwhelmed with referrals. Barbara mentioned here, it says, we have recommended that VHS Mental Health Board publicize and promote public comment opportunities. Is there a plan to do so? Is this something Kane Communication can assist with? Can you clarify the scope of their contract? So the only remaining Kane contract with VHS is through the end of this year. It's a very small contract, basically to sustain our recruitment and retention campaign for Crisis Mobile. But there is a position that we hope to hire that would be an internal county position who would report to Jill Linton, and our communications manager at DHHS. That individual would take the lead on really all the public awareness around our services, including the mental health board. We have had some improved attendance at some of our events. Montreal is a big part of that and has some good ideas. And really, we're looking to our community for ideas about how to get the word out. I think one of the challenges, people come out when they have something to talk about or something to advocate for. And the way our calendar works is there's a meeting, for instance, the September public hearing. The budget has been submitted, the state budget is complete. There's not a lot for people to comment on unless they have a personal issue, unless they have something they want to bring into our attention. We may be better off if we find sort of rallying points or things that people could get behind, and maybe do some shared advocacy for things like enhanced treatment benefit or better reimbursement rates or something along those lines to get more public interest. But again, I'm open to what the public has to say there. We get so much feedback from this group. There are many folks that reach out to us, and we do listen. We do build our policies based on the feedback we get. I mean, I think the Mental Health Emergency Center is the greatest example of that. If you recall, when I came here 7 years ago, I can't believe it's been 7 years. You'll recognize me. I didn't have gray hair at that time. There was a plan to build the North Side Hub, and there was going to be this giant facility on the north side. And all of our programs are going to be in there, and it was going to be this great thing. And then we went out in the community, and everyone's like, "Don't do that. We don't want that. We'd rather go places we feel safe, places we feel comfortable, places connected to our communities. That's really how we got embedded in our federally qualified health centers, because when we started to do the interviews and talk to the community members, they're like, we feel really comfortable going to 16th Street or Outreach, but we're not, particularly thrilled about going to your government clinic. And so we really abandoned that track, which, I mean, it was pretty much baked. I wasn't around for this, but it was pretty much a decision that was made. And it would have been the wrong decision, and we would have spent $35 million building a facility that nobody wanted. So getting feedback from our community is how we stay smart, how we stay on the cutting edge, and how we do that. It's really what we're committed to. And then I'm happy to answer questions. I think I probably overused my time, but if someone has a quick question, I'm happy to try to answer. I got a long question. Sure. Oh, that gentleman.
Hi, Mike.
Hi.
My name is, is that on?
Can you press the bottom?
My name is David Zaneski. I have a rather involved question, but I'll try to make it real brief. Individuals with intellectual disabilities and accompanying behavioral issues are often treated for mental health. You mentioned that there is a physician on staff that's supposed to evaluate anybody that comes into the emergency facility. Do they also take into account these individuals that have intellectual disabilities and aren't legally able to make decisions on their own behalf?
So the simple answer to a complex question is, in those assessments, would it consider someone's intellectual capacity or developmental capacity? But in Wisconsin, under Chapter 51, if you have an intellectual disability, you're excluded from that Chapter 51 process, and we can't even admit you to a hospital. So that ends up being the barriers. That there has to be something else. That was really the idea behind our clinical consultation team, and we still deploy staff to provide education and training, mostly in residential settings, but for people who work with that target group, to try to help teach people how to more effectively manage behaviors and try to avoid losing those stable placements. So often people have a great placement for a very long time. Something happens that destabilizes them. They're not equipped to deal with that moment or process that challenge. And it kind of creates this whole chaos around their placement. We've tried to get upstream and go out and help those organizations crisis plan and really come up with an individual plan that meets that person's needs to avoid some of those challenging interactions with police. But the bottom line is we can't really admit someone in those situations without a treatable mental illness under the statute.
Hi, my name is Heidi and I am a mental health RN from Milwaukee, VA. I actually developed a program at the VA where I assist the providers with monitoring and tracking our veterans that are on mental health commitments. I have providers that send extensions in with vast information of missed appointments, refused medications, and more than one provider per person, and extensions are being denied.
So the way the extensions work in Wisconsin, and particularly since DJ versus Langdon, a commitment to be extended, you have to demonstrate contemporaneous dangerousness. So simply missing your meds. This isn't probation, like a hospitalization or mental health commitment is really a punishment. It's supposed to be a treatment. And so what started to happen is these commitments were being extended for years and years and years and years based on one historical event from 10 years ago. A Supreme Court decision has changed that. So statewide, in order to be able to extend a commitment, you need to demonstrate contemporaneous dangerousness, or you really have to, the term I believe is a nexus of dangerousness must be described. So it can't just be missing an appointment. We also need the original fact witnesses. So I was part of a case yesterday where essentially we had to go back to the original act of dangerousness that led to a commitment. The witnesses were family didn't show up, the case got thrown out by the judge. So we at the county department essentially approve the documentation that is made up of that in that petition. So Dr. Schneider, when he looked at it, he's reviewed the petition. We always give feedback to the provider saying, look, this is not facially sufficient. We need more information. We might need a witness. We might need some more documentation. Simply saying this person was on commitment and they're mentally ill is not good enough. And I can't tell you how many petitions written by doctors come to us and say they need to be committed because they have a mental illness and they've been dangerous. And that's all they say. That is not something we can work with.
Well, and I do know of the one case where there were behaviors on the grounds. You know, where police were involved, the VA police and stuff, so I'll encourage the doctors to definitely focus on.
Yeah, and we actually did a training, Dr. Schneider created a training basically as a building on the experience of training the designees, explaining the civil commitment process and the expectations. You know, and words matter. I mean, I was just chatting with someone about this recently. So people always say that since I've been here for 7 years, people say, I went to PCS and they turned me away. Now they say, I went to mental health emergency center and they turned me away. That's not true. Everybody gets assessed. Everybody gets an mental assessment. But whether or not we can hold someone really depends on a couple of key factors. The person, against their will, they have to have a treatable mental illness. They have to have imminent dangerousness to self or others demonstrated. They can't be voluntary. And so I get frustrated parents who call me and say, well, we brought him there and they turned him away. I said, they didn't turn him away, but he didn't want to be there and we can't force you. And the law is very explicit. It says, if you don't meet the criteria that I just described, you shall immediately discharge. So that we can't keep the person, we have to discharge.
Well, in Milwaukee County follows or has to, because of population, different rules, because I work with Waukesha County and I mean, even like a med petition, they don't need a med petition. You're the doctor, you prescribe what you feel is appropriate.
I can't speak to the other counties that don't follow the law, but a med petition filed with every commitment would be illegal and a violation of those individual civil rights. And every county except Milwaukee does it. Because not everybody needs a med petition. So if someone's willing to take meds, maybe not the meds you want them to take, but if they're willing to take meds, that's their choice. And they should retain that right, unfortunately, and some counties don't care. So a lot of counties will initiate an emergency detention as well, and then the case will get thrown out at probable cause. So that's another challenge. So if a Milwaukee County resident gets picked up in Waukesha or the other counties, they're almost certainly going to end up at the state hospital, no matter what they did. That's just and then they transfer the venue to us, and then we pick up the pieces. But that's not great care, so we try to avoid that scenario. Yes.
Here's the tough one.
All right, lay it on me.
So
Mind if I sit down?
please, and you know what? I'm gonna sit down too. It's good. So I was gonna say, are you sitting down?
My spine is messed up. That's my problem.
Man, the last time I was in this room, we heard from a sheriff from the county, and he talked about the staff shortages, and I really empathize with him. Like, it stayed with me for a long time. There was a moment where he actually cut his finger while he was up here, and it helped me see more of a human connection of what's going on. As I listen to you and you go through the numbers, it gives me better insight of all the different things. The challenge that I have is I want to know if our effort is for naught. And the reason why I say that is in February, I brought 26 people to a public forum. 26 people got up, testimonies were given. I got not one call from Milwaukee County following up about all these people that had to be organized to come out in the same thing. This weekend, Friday date night, 8 o'clock, I get a call from a family. And instead of having a date with my wife for 2.5 hours, I'm on the phone providing resources for this family. The next day, we bring a therapist, paying out of pocket, a community-based responder. We're with the same family. Well, this same family, I did a co-response for Crisis Mobile with in February. And the thing is, we know the system is broken, or maybe it's working exactly the way it was designed. But it's hard when you have good guys like yourself that has this really big oversight of all these different departments, and you got young guys like myself that has innovation, and it seems like we can't make any progress. We've been having these talks for what, 3 years now? And in 3 years, I've put up over $96,000 of my own money. When I go out and help these people, I'm spending my own hard-earned cash that didn't come from any mental health resources. And it's discouraging because I can get a call from Racine like I did today. Arms wide open. Montreal, yeah, let's work, let's come. But in my own hometown, it's just so frustrating to hear all of the challenges we have with staffing, but we're not looking at innovative solutions. Everything, and this is not towards Mike, this is more towards leadership as a whole. Everything in this world is becoming autonomous. The reason why this room isn't filled is because people are virtual. But we've prevented over 9 suicides since November. We helped over 743 families last year. And I've gotten to a place where the devil almost got in my mind and said, people won't show up for you, Montreal. They won't help you. They won't be there. You know, we did a fundraiser in July where we had our mindfulness mocktails, a great event. I spent over $10,000 on that event. We fundraised $46. And when you have counties that have a budget, how do I know? Because they can afford to hire people that don't want to work. You have organizations that have people, but we can't get the contract. Where do we go forward? Because everybody on every level feels like it's someone else's department. And when I come here and I have to find transportation for my son to be brought here from Brown Deer, I have to pack up all this equipment. I keep serving in every capacity. It's just frustrating. And it sent me through depression from December 18th until April 28th. I've never dealt with depression in that way before because I'm like, man, this is my hometown. And I do all these things. I show up for the young people. I volunteer. I'm working at the detention center for free now. I'm getting the young people out. I'm taking them shopping. I'm helping them with back to school supplies, but I can't get a break. And it's like the process to apply gets lost in workflow, rigmarole, and jargon. And it's like, if nothing exists like the mirror response team where we monitor your heart signs, we use assistive technology like Apple Watches, Samsung Watches, we come up with crisis management plans, we work with the family, and we're able to respond in 30 minutes. What does it take to get a pilot done in this city? Because the money's there. The budgets are public.
Well, just to directly respond, I mean, you brought 26 people to talk about a proposal that I never saw. I heard about a proposal from the city. And I still have never seen, we will deliver these services to this population for this dollar amount, Montreal. I've never seen that. And we don't have unlimited funds, but we do have crisis funds. Sure. We support all kinds of innovative services and programs. Pretty much everything we did started out as an innovative service and program. You know, we started Crisis Mobile in 1980. You know, 8 major US cities are just looking into it now. Something we've been doing, you know, for 40 years. So it's not that we don't support these things, but there are parameters that we operate under. The other piece is most of our services have to be delivered under the DHS 34 crisis benefit, which isn't my rule. Only counties can deliver that service. That's where the funding goes. That's how we can fund things like CRC and crisis and CART. And because the state allows us essentially to be made whole, we're only responsible for what we had expended in that program in 2017. So our maintenance of effort of the county match is capped. That allows us pretty much unlimited growth, but it has to be delivered within those parameters.
Thank you so much. The beautiful thing about this is that link to that proposal was on the city's website. Mary helped, you know, write it with a lot of people, and it's not your fault, but the city actually took it down because it was a really good plan. I got a call that asked me not to propose the proposal I did and to remove it. And so it's so much bureaucracy in the city that it's like you can't get anything done. In addition to that, I'll make sure that you get it directly. I did send it to someone in your office. And it's not a mic thing. Like, we cool. You instrumentalist, I'm an instrumentalist. We can be great, right? But the reality is who's going to be brave and stand up and say, you know what? Let's take another look at this. The evidence-based research Montreal has presented with his team, the money that he's put up, the testimonies, the videos, there's no way to deny it at this point, but what happens is there's no pressure. So while I'm really excited to be in this room, I got a couple more years left to keep making some noise. And I'm at a space now where it's like, I put my money where my mouth is. And so when we talk about DHS 34, that's amazing. ARPA dollars is amazing. Where the city, the state, and the county went wrong is they showed us they could release funds in very innovative ways. 6 particular areas of ARPA dollars says that if there's a behavioral health need, that we can allocate those funds. But if no one's following through, if we're getting lost in the workflow, all of those people that are now roaming the streets that we knew would roam the streets when we closed the building that had the capacity are still out there. If we look at Granite Hills and say, hey, we've had 24 beds. And now we're at 36. What fraction of people are we really serving? And so when we look at these contracts and we're not applying pressure in any of these areas, there's not only room for innovation, people just have to say, you know what? I don't like Montreal, so I ain't never working with him. Just say it. Or give me a second chance because I never got the first one. Let's sit down and have a conversation. Me, you, David Muhammad, Muhammad, Shakita LeGrant, David Crawley, let's all actually just have a conversation and see if it's really viable. Because at this point, if I have to leave this city, I'm gonna be pissed when I come back to do what I already started here. Thank you.
I'm assuming we're at time. Well, thanks, everybody. I believe you all know how to get a hold of me. Barbara usually puts my contact information in the minutes. If you want to reach out, there's something I can address.
Good afternoon, everybody. I'm Mary Neubauer, the co-chair of the Mental Health Task Force. And encourage you to hang on a little bit. We've got some interesting things here at the end. I'd like to talk to you a little bit about I can't even see the clock, there's a glare. I'll make it quick.
It's never right. It's 5:01.
It's 5:01. I'll make this real quick. Okay, I just wanted to tell you a few things about the mental health board. And the first thing is that the board is at full capacity. We have added Mr. Richard Cantor to the board. He replaced Tom Lutzow, who was our finance person. The second thing is in the upcoming months, not too distant future, there will be a board retreat for the Milwaukee County Mental Health Board. Number 3, let's see if I could read my own writing. Number 3, there is all of the board meetings now for the mental health board are in person. Number 4, there was a quality meeting yesterday of the mental health board. And it was a very productive board meeting. And as Mike pointed out, the next board meeting will take place 3 months from yesterday, which is the second Monday in December. And at that board meeting will be a full report about the metric on the Mental Health Emergency Center, and that we have public comment coming up for the public comment session on September 28th at 4:30 at the Washington Park Community Center. So that is what I wanted to say about that. And I encourage people to stay online, because at this point in time, I'd like to have Barbara Becker come up to the podium. Well, actually, Martina, what are you doing? Anything important? Come on, Martina. Barbara. Barbara. Martina. As one of the past co-chairs, would you like to make some comments about Barbara Becker? This is Barbara's last meeting, because Barbara, as director of Disability Rights Wisconsin and external advocacy director for Disability Rights Wisconsin, and the amazing coordinator of the Mental Health Task Force, is retiring. And this is her last meeting with us. So I'd like to turn the microphone over to Martina at this point in time as one of the past co-chairs of the Mental Health Task Force to say a few words about Barbara.
Thanks, Mary. I will keep this very brief. Many of us, yes, okay. Many of us have had a chance to acknowledge Barbara, but I'm excited to do this again for the task force. So Barbara has been a part of my career, but also has been an amazing support and ambassador for Mental Health America of Wisconsin. So we do a lot of advocacy work. And as I was coming along and getting to know how all this works, you really have been a cheerleader. And I just want to thank you for your support, not only in me, but in the organization, and always being this incredible ambassador for Mental Health America. I, like many of you in this room, have learned so much. And a few weeks ago, we had a separate celebration in a park celebrating Barbara's retirement. And, you know, the buzz around the park was, oh, what are we going to do without Barbara? What are we going to do? We can't. And I was right there with them, the rhetoric. And then it just dawned on me, no, we know exactly what to do. She's trained us well. So I want you to know, job well done. We will carry the torch and do what you've taught us. So thank you for all. Robin. Thank you. There you go, Robin.
Well, I'm not that great at speaking. Barbara has taught me so much in mental health advocacy issues and helping me to be a stronger advocate. Working with Sojourner, giving them resources and everything. And she has really supported me in my recovery with everything I've been through. So I'm going to miss you terribly, but I know we'll see you again. Thank you for being present.
Oh, Christine, you want to go first, Mike?
I would just say something really quick. So when I got hired in this job, I knew Barbara from before. And in the Bill Glover story announcing me, describing my job as the hardest job in county government, he quoted Barbara Beckert and it said, we're confident that Mike is going to do the right thing, essentially. And I was like, okay, well now, now if I mess it up, it's my fault. So so I have always appreciated that and the warm welcome and then all the advocacy going back 20 years. So you have put an indelible mark on the mental health system in Milwaukee and we will all try to keep it going. So thank you.
Thank you so much.
Well, thank you.
My name is Shanika Fitch. I am the Director of Community Relations in the Office of County Executive David Crowley. And on his behalf, I am here to present an executive proclamation to Barbara Beckert. So it reads as follows. Whereas Barbara Beckert currently serves as the Director of the Milwaukee County Office and External Advocacy for Disability Rights, Wisconsin. And whereas beyond this, Barbara has also served as the coordinator of the Milwaukee Mental Health Task Force, where she pulled together the agenda and PowerPoints for speaking at every meeting each year. And whereas Barbara worked side by side with 8 different co-chairs for the Mental Health Task Force, always doing extra work behind the scenes for the benefit of the Milwaukee County Mental Health Board. And whereas Barbara diligently worked on many special conferences through excellent collaboration and consistently poured her soul into Karen Avery forums. And whereas on September 12th, 2023, Barbara gathered with peers and loved ones as they honored her in the Aretha way, with respect. Now forever, David Crowley, County Executive of Milwaukee County, on September 12th, 2023, does hereby recognize and honor the service of Barbara Beckert on the occasion of her retirement and thank her for many years of service to the people of Milwaukee County and beyond. Thank you so much.
Thank you, everyone. I know everyone's anxious to get going and we ran a little late, but just we're running over. Don't worry. Yeah, but thank you so much. It's really been a joy to be a partner in this task force and to work with so many amazing advocates. And I know Milwaukee County is going to be well served by this mental health task force moving forward. And especially want to thank Christine and Mary, you're just incredible leaders, and we're so fortunate to have you and to have had such a great array of chairs over the years. And it's wonderful to have you here with us, Martina, to bring back lots of good memories. And so many of you have been here with us every step of the way, like Denise Johnson. So thanks everyone for the partnership, and thank you, Mike, for all that you do and your partnership with the task force. And Robin, you're a dear friend. So I will stop now.
Just a quick note, Barbara, I just want to say thank you for all you've done for everybody, countless human beings you've helped with all of your advocacy work. When I first met Barbara, I was very much in awe, thinking, wow, she really has an interesting way of speaking. I'd never heard anyone speak the way you do, and just so polite and so kind and so ingratiating. But at the same time, you kind of gave a message every time you spoke, and I'm like, she really knows how to be persuasive to people in a way that I've never seen anyone do before. And so you're a role model, and I just want to thank you personally, because when I came to the task force, I felt like an outsider working in corrections. You had every reason to say you're them, you're the people we kind of want to advocate for because you're bad. But you said, no, you become an advocate too. You have a seat at the table and you have a voice to use. And instead of kind of shunning me, you welcomed me and told me, come be on the committee, come try to be on the mental health board. So I really thank you for your advocacy for me having a voice so that I could have a voice for others. So many thanks and well-deserved retirement.
Oh, such a journey, such a journey, such a journey. 18 years of working with Barbara Becker. It has been truly a gift, truly a blessing, and truly an honor to work with such a fine, fine woman, and such a gifted woman, and a woman that has taught me much, as well has calmed my horses in many ways, in the way that learning to be more diplomatic. And that has been my gift from Barbara, learning to be more diplomatic. And that is truly what I take away and will walk out of these doors with today. Barbara has become a true friend, a true spirit of mine, and has been a guide. I will miss you. I will miss you. I will miss you, but I will have you at my side every day. And I will know who to look for. And I will know you are there because you have given so much to me. And I know that our paths will cross again, and that you'll be out there. But I also know you will be hiking those mountains and traveling those trails and riding your bike and then doing those things with Ed that you need to do. And hopefully someday soon, toddling with little grandchildren across the living room. That is my dream for you. So Barbara, please come back up here. This is your temporary standby trophy for being the most wonderful coordinator for the mental health task force, because yours has not come in as with the pandemic situation, but actually because of my health situation, it is quite the beauty that is coming. So the standby today that I can't hold on to much longer for the retirement, hold this piece because it's popping out. Gotta hold this piece. Notice it has no.
Stop, you're gonna fire me.
No, you're not fired. Notice it has beautiful purple in it,
Oh, it does. It was
all the way
gorgeous.
around.
I don't want to break it.
Don't turn it around, just hold it up. See, and you can see Barbara's face through there. Beautiful purple. So Barbara, in honor of the Milwaukee Mental Health Task Force, it's beautiful. We congratulate you on your retirement on September 13th, 2023. as you depart from Independence First at your last mental health task force meeting. Let's give Barbara a round of applause.
Everyone, thanks for sticking around.
Please grab a cupcake in the back in honor of Barbara and cookies. They are in purple and pink. Help yourself. Thank you for being here with us today. And our next meeting will be October 13th at this location. Enjoy the music as you wander out.
Not so far.